Hi everyone, it's Steve Knight with another Consensus Medical Systems Blood Flow Minute. I want to talk about Doppler angles because I think they're largely misunderstood by those of us who didn't benefit from robust instruction in this area. I was trained in vascular technology on the job, and I learned about Doppler and ultrasound physics by reading everything I could get my hands on and sitting in the front row at conferences so that I could ask lots of questions. There weren't any college programs specifically for vascular testing, and attending one at that stage of my life just wasn't in the cards. Like so many of my generation, my technical skills were developed on the job, but the theory that went hand in hand with that came from self-directed study. One thing that was beaten into my head was, "Thou shalt not exceed 60 degrees." Well, this mantra, along with carotid stenosis criteria that were published around the same time, locked a mindset into doing everything at 60 degrees. And while this is critical for the first few centimeters of the internal carotid artery, it didn't apply to other arteries supplying other vascular beds. The result of this is that there have been several generations of duplexers who dogmatically set the Doppler correction cursor at 60 degrees. But why should we never exceed a 60-degree angle correction? And if greater than 60 is a problem, how safe is it to use 60 degrees? What if we're off by 2 or 3 degrees when we think we have angle corrected parallel to the vessel wall to the best of our ability? What if the stenosis is on a curve? These are all challenging questions, and I want to shed some light on this dilemma for those of you who have swallowed the 60-degree or bust dogma without understanding where the concern comes from. While I admire consistency, we should understand the risk that we take with the data we acquire at 60 degrees. To paraphrase Winston Churchill talking about democracy and loosely applying it to our field, the Doppler equation isn't a good system for estimating velocity, but it's the best one we've got. Let's take a brief look at the Doppler formula, and then let's look at the cosine table. This has been rearranged to solve for velocity because that's what we're interested in. But if we eliminate the variables in the formula that don't change from beat to beat, the only thing that has any effect on velocity is the cosine of the angle theta. Here's a mock-up of an artery with the Doppler beam angle shown in yellow and the Doppler correction angle shown in green. And what's important is the angle between these two lines. That is our angle theta. But what happens if our angle theta is off by 3 degrees in spite of our best efforts? To answer this, we need to look at the cosine table. Here we can see our old friend 60 degrees with a cosine of 0.5. The angle of 63 has a cosine value of about 0.45, which is a difference of nearly 5%. That doesn't sound like much, but when you multiply that by a velocity in the hundreds, the difference can become substantial. If you're off by as little as 3 degrees when using a 60-degree angle, your error can put you from 220 centimeters per second up to greater than 230, which may suggest a greater than 70% stenosis. That may trigger an entirely different cascade of medical management for the patient. The opposite can happen as well. Someone with a true velocity that falls into a category of significant disease may have a finding of lesser severity. Now here are 2 images of the proximal renal artery. I took this a long time ago, and admittedly it's not the best example because the patient has an arrhythmia. The image on the left was obtained in the typical AP direction with the patient supine. The image on the right obtained from the flank in a lateral decubitus position. Look at the difference in velocities. Why the discrepancy? In the AP orientation, the proximal renal artery has a curve, and the Doppler sample volume falls right on that curve. The error between 0 and 3 degrees is only about 1/10 of 1%. To have the same magnitude of that 3-degree error at 60, you would need to be off by nearly 20 degrees if you're using a Doppler angle of 0 degrees. If you don't trust me, get a calculator and look at the numbers for yourself. It's for this reason that we don't angle correct when we're doing TCD or cardiac Doppler. Angle correction doesn't change velocity measurements enough to warrant the effort, and the velocity criteria have been established using zero angle correction. Now, having said all that, it's important for me to emphasize a few key things. One is that you can reduce the chance of error by optimizing your color so that it doesn't bleed over the wall of the vessel, obscuring the native lumen. Better still, if your velocity is close to a cutoff value, turn the color off altogether and get your best measurement. When possible, use a low angle of incidence to reduce error from incorrect Doppler cursor placement. I can think of two good examples of this. One was the renal artery I just showed you, and the other instance comes to mind is the origin of a dialysis axis at the fistula. I always make an attempt to measure at the lowest possible angle. That's not always easy and it takes a lot of gel, but I have a greater confidence when the Doppler beam angle is close to zero. And if you think about it, if you get an abnormal velocity at 0 degrees, it's definitely abnormal because the calculated velocity can't get any lower. You can't possibly manipulate the correction to get a normal velocity. Now, it's rare that we can interrogate the proximal ICA at 0 degrees, which is one of the reasons why the original validation studies on this were done at 60 degrees. That and the cosine of 60 degrees has a mathematically convenient value of 0.5. But this is problematic with other arteries that lay parallel to the skin line. And the debate about angling parallel to the vessel wall versus parallel to the flow stream will rage on for the foreseeable future, but I do urge you to set the angle correction parallel to the vessel wall, and I'll talk more about that in the future. Until then, this has been another Consensus Medical Systems Blood Flow Minute.